Hello, my name's Ken Kinter, and I'm an assistant professor at Rutgers University in the Department of Psychiatric Rehabilitation and Counseling Professions. This is Introduction to Safewards. It's meant to be, as it says, an introduction to Safewards, and also hopefully as an assist for people that are doing training, especially train-the-trainer model in Safewards. At the time of this recording, the state hospitals in New Jersey are implementing Safewards as an attempt to increase safety, improve morale, and hopefully improve discharge rates at the state psychiatric hospitals. Now, this graph here is a little complicated. We're going to go through it quickly, and there's a simplified version immediately following. The main point of this is that there are many different dimensions to violence. So starting in the 12 o'clock position here, you have elements of the patient community, patient characteristics, the regulatory framework, staff, physical environment, and external influences. Now, underneath all of these, you have stressors that can increase the risk of violence, decrease the risk of violence, and certain flashpoints that are things that can immediately result in violence happening. And at the center here, you have conflict and containment, which is also known as violence, seclusion, restraint, IM medications, and so forth. So this is a stripped down version of that, just to make it a little more simpler. Again, in the beginning, in the middle here, we have violence, and there are the flashpoints again. So again, going clockwise from the top. So we know that some staffing factors contribute to violence. If there aren't enough staff, if the staff aren't familiar with the patients, if the staff are particularly burned out, but also if the staff are very authoritarian is another important one to add on there. Moving down to external events, there's some people that are set off by visits or phone calls with family, or significant events can happen on the outside. The loss of a loved one, someone being sick, something that, the person's in the hospital, they're away from where this issue is. That can contribute to violence. You have environmental factors, policies and procedures, hospital rules, even something like the overall volume level on a unit can increase the risk of violence, and also how crowded a hospital is. And then we also have the patient factors. Patient factors, how familiar is the patient with violence? Have they used violence to get their way before? Is violence something they're very familiar with and very comfortable around? Or are they traumatized and anything that is remotely violent can trigger a fight or flight response in them? And so these factors, either in isolation or together, can hit these flashpoints, and then violence becomes the result. So what we have here are the 10 primary Safewards interventions. The way that we've been implementing them is by starting with number 1, as you see in the boldface, starting with these community meetings. There are several of these interventions that are poster-oriented. So, for example, clear mutual expectations has to do with daily community meetings, and also the creation of posters that go up throughout the unit and the nurses station as artifacts to remind people of the changes that are taking place and to help correct behavior. Soft words, similarly, a poster-driven intervention where different words that represent the philosophy of the unit are around in the unit for use by patients and staff. Positive words is the idea in nursing report that any potential liability or dangerous situation, for everything negative that's said, there should be something positive said as well. Talking down, how do we de-escalate? What do we say to de-escalate people when they're in that agitated state, maybe a pre-violent state? Bad news mitigation. How do we plan when we're breaking bad news to a client? How do we do that taking that person's factors in mind? Is this a person who needs a lot of support and contact with people? Is it someone that wants to be left alone after they've gotten bad news? Just taking the person themselves into consideration when bringing this. Reassurance. How do we provide reassurance to patients when they are reacting to a potentially traumatic or re-traumatizing situation? Calm down methods involves the creation of a calming box. Other places have also used a cart where there are items that person can reuse to reduce their stress level when they are in that agitated, maybe pre-violent state. Mutual help meetings, again, these are the meetings that happen once or twice a week, give patients more opportunity to talk specifically here to thank people for helping them in any way and also to provide suggestions about how to make the unit better, how to prevent violence, etc. Again, the mutual part of that is that the patients have a direct say in these meetings. 9 is the Know Each Other folder. Now, this is information about the staff to try to make them more accessible to the patients. Now, we need to be realistic about this. We're not necessarily going to talk about where your kids go to school or your home address or anything like that. Very basic level. Sports teams. What kind of ice cream do you like? Is there some hobby that you feel, comfortable disclosing? Okay, if I like to go kayaking, I think that's pretty safe. Again, at a facility like a state hospital, we tend to be very guarded with our personal information, and rightly so. But that doesn't mean we should be completely inaccessible. And there should be an avenue to communicate to staff apart from, you're my social worker, you're my psychologist. We can be a little more personable than that. After all, sometimes we wear personal effects that give some clue as to who we are and what we like to do outside of work. Number 10 is discharge messages. Patients that are nearing discharge, being discharged, are encouraged to write a message or to meet in the community meetings about expressing what helped them, and to be sort of a living testimony as to, look, people get discharged from here, people leave, I left, who's next? So any words of hope or anything that helped that person get to the point of discharge is a good thing. So now the way we started out by doing 3 of these interventions. Every unit got to pick the 3 interventions that they were either closest to already accomplishing or the ones that they saw as being the most need for, and then adding in another 1, 2, 3 at a time until all 10 are completed. And there has been variation in each unit. We let units have the autonomy to pick which ones they're going to go to first. Now, another important element of Safewards implementation is fidelity. How do we know that a given intervention has actually been done? So what you have here is a list of all of the Safewards interventions and suggested, and this is from their literature, suggested fidelity implements. So if you were going to do a review and go through the unit and see, okay, well, where is that clear mutual expectations poster? Is there a process by which new people get to see that poster? If there's a calm down box, then where are the elements in that calm down box? Where are they? So fidelity is very important, because to have an implementation of any sort be sustainable, it has to be everywhere. There has to be that presence of it everywhere throughout the hospital, but then also fidelity. So this is sort of a template that could be used. There's a sample template in the Safewards on their website, safewards.net. And then this is something that we created based on that we could use specifically in the hospital. So our plan is to implement these interventions in the next few months. Like I said, we're part of the way into it now. If there are suggestions, if you look in the Safewards materials, there are additional interventions apart from these 10, if that's seen as something that could help, or if something gets suggested by the patients or by the staff that would be helpful and in line with the Safewards philosophy, let's add those as well. We want to change how we interact with each other. We speak with each other in a much more respectful, supportive, and therapeutic way. We also want to track other numbers that would indicate whether the Safewards philosophy is working. Are assaults down? Are injuries down? Are restraints down? Seclusions down? PRNs down? These are all evidence of a safer unit. And then ultimately, to increase the morale, job satisfaction, and the discharge rate. The goal of Safewards is to make the unit a safer place, and a place where more therapeutic things can happen, and a safer and more enjoyable place to work and to reside. So again, if there are any other information about this that you need, you have my contact information on the first slide, and the safewards.net website is excellent. All sorts of additional information, pretty much anything you would need, including samples of how other places have taken on each of these interventions, is also there. So I would definitely recommend that. Anyway, thank you, and hope this helped.